Okay, let's go ahead and get started. Lucky or not lucky, we won't be doing any questions today either because there seems to be an issue with it. So new systems always take a little time to get worked out. Nonetheless, we will pick up where we left off last time. We were talking about structural features, structure and function. We kind of talked about this right here. We talked about these are the terminal bronchioles, respiratory bronchioles, alveoli. You can see how it branches out. And we talked about how the respiratory sections of the respiratory tree that are involved in gas exchange. Those occur at the respiratory bronchioles. The terminal bronchioles are kind of at the end where of the conducting zone before you get into the respiratory zone. And also we talked about the alveolar surface area, how large it was, and also that the capillary surface area in contact with that epithelial surface area is about 96%. And we talked about how thin of a layer of blood that is that's exposed to the alveolar surface area. This here is just another micrograph looking at terminal and respiratory bronchioles. You can see how they all come in, and actually all of these alveoli are all interconnected through these little small alveolar pores. This is a much better picture. Here you can see in the alveoli, these are the septae that separate the alveoli, but look at the multiple pores and connectivity between these alveoli. So it's important to understand that all these alveoli are still very much connected, and we're going to talk about the importance of that when we talk about equal and equivalent inflation of these alveoli so that they all inflate equally at the same time. It's very important when we take in a breath. And here you can see, once again, this is a macrophage that is into the alveolar space, and that thing's just moseying around, seeing what it can pick up for dust, bacteria, viruses, any kind of particles that don't belong there. Once again, this is another image looking at the variable size of the alveoli and how important it is. Now, if you look at here, you can see how large these alveoli are. And so what we're looking at here is a loss of surface area. So as these alveoli become larger, we lose surface area because a lot of little alveoli give you much more surface area. And we're going to talk about this when we refer to emphysema. Emphysema is where we lose a lot of our surface area that's available for gas exchange. So that's one of the biggest problems with emphysema is that all these small alveoli, we have a deterioration of the septae, those borders between the alveoli, and then they form these large alveoli, but we lose a large amount of surface area. So we're also going to talk a little bit about the circulation. Now, when we talk about pulmonary vasculature, the transition or the gas exchange between the alveoli and the vasculature, that's mostly the blood that's coming from the pulmonary artery. So in this case, the pulmonary artery, and in this case, they represent this inappropriately because pulmonary artery, as we know, is deoxygenated blood. So actually, that should be more blue than red. And down here, the pulmonary vein is oxygenated blood, so this should be red and not blue. So make sure you understand that because this is the way the image is in the book. So what we have is from the blood coming from the pulmonary artery, branches down through the branches, and it follows the branches of the airway, and then it branches out and will actually create a capillary bed surrounding each of these alveoli. So that's where our gas exchange comes from. But when we talk about the circulation or blood flow to the trachea, to the bronchioles, to the airway, even to the lung parenchyma, a lot of that blood flow comes from the bronchial artery. So that blood circulation to bring nutrients and support to those tissues comes from a different circulation. So that comes from the bronchial artery coming off the aorta. That has a high PO2, unlike the pulmonary artery, which has a low PO2. So all of the tissues in the lung most of them are all supported by oxygenated blood coming from this bronchial circulation. So there are two separate circulations within the lung, one that supports the tissue and the other that's primarily involved in gas exchange. So remember that they are two separate entities. And also we're going to talk a little more about the lymphatics a little bit when we're talking about pulmonary edema. So the lymphatics also follow this circulation, and they are responsible for maintaining a homeostasis in fluid content of the tissue. So a lot of the excess fluid will move through the lymphatics, as well as it's important for elimination of the macrophages as they digest and pick up bacteria, infection, any other particles. The lymphatics help to remove that from the system as well, from the tissue. This here is a little more comprehensive image showing the breakdown of the airway, the pulmonary artery. Here it's more correct, it is blue. So the pulmonary artery coming in following the airway, and then as it branches, you can see this capillary network that surrounds each of the alveoli, and then it feeds back into the pulmonary veins. So this is a very complex, and it's what you're also going to see here. See these bands that surround these alveoli. Those are elastic fibers. Those are within the interstitium between the epithelial surface of the alveoli and the capillary bed. So they sit in there, and those are very important as far as exhalation. Remember, we said when you exhale, it's a relaxation and it's a recoil of the lung, and that recoil is what causes exhalation, and that's due to these elastic fibers. They're like rubber bands sitting around these alveoli, around the lung. So as you actively expand them and then relax, they will contract and cause exhalation. So once again, you can see the breakdown of here. The lymphatic vessels are all interspersed as well. Those are some of the main points you're going to have to want to know. Now also, we already mentioned a little bit about chronic obstructive pulmonary disease, or COPD. Remember, we mentioned this is conductive airway disease more primarily. And air exchange is impaired due to narrowing of the airways. Primary cause is smoking. So anything that causes a narrowing of the airways, and two examples of that are chronic bronchitis. And in chronic bronchitis, basically the patient will have a bluish tinge to their skin color. They're usually overweight, excessive mucus production, general inflammation of the entire respiratory tract. So this causes a narrowing of the airways. Therefore, they are not getting enough oxygen. If they're not getting enough oxygen, that's what causes the bluish tinge to their skin color. And also, an example of COPD is emphysema. Emphysema is a very complex disease, and it affects multitude of aspects of pulmonary physiology. But with respect to COPD, we have typically a normal pink skin coloration, so they are getting enough oxygenation. However, the patients are typically quite thin, and we're going to talk about that more when we talk more in depth about emphysema, but they're thin because in emphysema, we have a loss of that elastic fiber that surrounds those alveoli, as I mentioned, and in emphysema, if the alveoli or the lung cannot recoil to exhale, the only way to exhale is to do active exhalation. In other words, now you have to use your internal intercostal muscles, your abdominal muscles, and you have to force the air out of your lungs. So the recoil doesn't push it out. So now you actively push it out. So you consume a large amount of energy breathing if you have emphysema. And that's why these patients are typically thin, because they're utilizing so much energy just to breathe. Okay? So that's very important to understand that. And so you basically get shallow breaths, rapid breaths, loss of elastin and elastic recoil, difficulty in exhalation, and therefore increase in work of breathing. So keep these in mind, but in the case of emphysema, when we're talking about COPD, it's not as much of the loss of elastin that creates the COPD, it's more so the airway occlusion, because with emphysema, you also get a lot of mucus accumulation in the airways, etc. So that's where we get the narrowing of the airways with the other aspects associated with emphysema. So here we continue. We're going to talk more about the vasculature now, the pulmonary vasculature, the pulmonary artery and capillary network. You can see the main vessels coming in. This is the pulmonary artery, and then it branches down. And these are all the vascular networks associated with the alveoli. So you can see it almost completely covers as much as the epithelial surface of the alveoli, but instead this is just a microvasculature that surrounds them. But you see how closely it follows the septae and the divisions within those alveoli. So here we go once again, the capillary network. We saw this picture before. It's very vast. This is just a very high magnification. And the diameter of these vessels are so small that the red blood cells travel through them in single file. Another type of picture looking at it on a little broader spectrum, looking at the capillary network, forms continuous sheets practically. And this image here, you can really see the red blood cells. These are all individual red blood cells following through, and these are the alveolar spaces. So once again, you can see how close the airspace is to the bloodstream, so that when we have an exchange of oxygen and CO2, it can occur quite easily. This is a little different view, and this is an important view right here, and this is what I want you to pay close attention to. Once again, we have our airspace up here for gas exchange. This here is a red blood cell within the lumen of the capillary. Now look closely at these membranes. This membrane here, this is an epithelial cell, a type 1 epithelial cell. We're going to talk more specifically about the cells in the alveoli. Type 1 epithelial cell, very thin and elongated. So this is the epithelium, that's what the E here is for. And you can see how thin that is. Now, as what we have here, this is the blood vessel. So this is the endothelial cell that surrounds the blood vessel. And you see the single endothelial cell surrounds the entire capillary. This here is the nucleus of the endothelial cell. Now, if we were to look at this, we just happen to have on this cross-section going through the nucleus. Typically, the nucleus is a small point. The cell itself is much more spread out. So if we were proximal or distal to this, we would see just a thin layer continuing across here for the endothelial cell. But in this case, we get a cross-section of the nucleus. So you can see once again, the epithelial cell and the endothelial cell are practically touching each other and bound to each other. There is, however, this very small, thin separation between these two membranes, and that's where we have our interstitium. That's where you'll find the elastic fibers. And that's also where we'll talk about when we have edema and fluid accumulation between these basement membranes of these two cell types. So that'll be interstitial fluid is found in that small space. And you can see how important that's going to be. If we have a large amount of fluid build up in between here, it separates those membranes farther apart, and we have a greater distance for the gas to diffuse. So make sure you understand that quite well, and this is actually a real picture so you can get a good feeling of what that looks like. And here, this is just a rendition of the same thing. Once again, looking at the epithelial cell relative to the endothelial cell. And as well, like I said, there's elastic fibers that sometimes sit in between here. So elastin and collagen are your basic extracellular matrix that you're going to find in the interstitium and between those layers. And this is kind of what it looks like if you take a big slice view of it. Once again, this is the epithelial cells on the surface. These are type 1 epithelial cells. Type 1 epithelial cells cover 96 to 98% of the surface of the alveoli, of the epithelial surface. However, they are an equal number with the type 2 cells. So what does that tell you? If epithelial type 1 cells cover 98% of the surface, but there's still equal number of type 2 cells, you can tell that their morphology is quite different. So a type 1 cell is very thin, very elongated, very spread out. A type 2 cell is columnar. In other words, it's tall, it's thick, and type 2 cells are not involved in gas exchange. So type 1 cells are involved in gas exchange. The epithelial type 2 cells, their primary function is to secrete surfactant. We're going to talk much more detail about surfactant, but surfactant lowers surface tension. And we're going to talk about surface tension in much more detail. But to give you an example of what surface tension is, it's like if you blow bubbles. You know, you take that little ring, you put it in a soapy solution, you blow a bubble, and how big it gets or how small it gets, that's all dependent upon surface tension of the fluid. Okay, so that's the same type of surface tension that we're talking about here. Because remember, we mentioned already that the epithelial cells themselves are actually covered with a thin layer of fluid. And that fluid is what dictates the surface tension and the expansion of the alveoli, just like it would in a bubble as you blow it from a ring. So also back to the type 2 cells, they secrete surfactant, which decreases surface tension, but also the type 2 cells are important for repair and replacement of epithelial type 1 cells. They're considered a progenitor cell for type 1 cells. So if we have lung injury, the epithelium gets damaged, it's the type 2 cells that will differentiate to type 1 cells and replace them. So the type 2 cells also serve a very important function with that regard. Here we take and we remove the epithelium, and now we see the vasculature underneath. And you can kind of see where these elastin fibers are all integrated within that extracellular matrix between those two layers. And these elastic fibers are very important for the recoil and exhalation of gas as we breathe. So here you can see, once again, the fibrous elastic strands. The elastic fibers are very important for expiration to make it passive. As we mentioned, loss of elastic coil gives us emphysema. Excess elastic fibers, or collagen, gives us pulmonary fibrosis. So if we have too much extracellular matrix, and primarily we're going to talk about collagen, not necessarily elastin, but an increase in collagen makes the lungs very stiff and makes it very difficult to expand those. And that can be caused by a variety of different diseases. But typically it's called pulmonary fibrosis. It can be caused by infections, lung injury, anything along that line that actually affects the parenchyma of the cells, which can also occur through autoimmune or injury. So any types of autoimmune diseases that creates an inflammatory response within the lung can cause pulmonary fibrosis. And as we see here, the lymphatics, once again, they follow quite excessively the vasculature. So if you can see just the lymphatics, you can see how they also cover the same area. And they're very important for what I mentioned before, collecting interstitial fluid and returning it to the venous circulation. So they help maintain a fluid homeostasis within the lung. So this here, once again, points out the main points that we talked about. We talked about the air space here, the epithelial type 1 cells. We have this small little barrier in between of extracellular matrix. As well, we have the endothelial cell here, and of course the nucleus is somewhere to be found, as well as in the epithelial cell there's a nucleus associated with that as well. But they just put that in that the nucleus does give it a little broader spectrum. But the nucleus is very small relative to the whole size of the cell itself. So there's also vascular smooth muscle cells associated within the underneath, depending on what level we're at within the trachea and with the vasculature. We do not see a lot of vascular smooth muscle cells at the alveolar space, but this is where they would be found, is kind of underneath the epithelial cells. And of course, the surfactants released, and sometimes these basement membranes are actually fused together lightly. So what that fusion is, it just helps to hold their proximity, but that can be increased and pulled apart quite easily by interstitial fluid that increases. So this is just an overview of everything we talked about, the different cell types, the elastic fibers. Don't forget, the macrophages that migrate and work through here. So there's a lot of macrophages come from the circulation into the alveolar space. But because the proximity is so close, these macrophages are able to get between the cells. They can squeeze through very small spots, spaces within there. And once again, type 2 cells. Type 2 cells are kind of found, if you look at an alveoli where junctions come together from septae of the alveoli, that's typically where you'll find type 2 cells, is in those junctions. So they kind of stick to the corners, more or less, of the alveoli, while the type 1 epithelial cells cover the majority of the surface. So once again, here's an epithelial type 2 cell secreting surfactant through pores. These are what it looks like, some of the pores. You can see the type 2 cell kind of sticks up and above the type 1 cells. And this here, once again, just mentions that the secretion of surfactants is very important. And we also have this interstitial space. This interstitial space, 0.5 microns. Very small, very important to maintain it small because we need to have oxygen diffusing from the airspace into the blood, as well as CO2 diffusing from the blood into the airspace, so we get appropriate transfer. And earlier we mentioned that one of the functions of the lung is to clear the blood of a variety of different circulating products, whether they're hormones secreted by other tissues, so they'll inactivate serotonin, norepinephrine, bradykinin. And they also produce prostaglandin, peptides. As well, the lung is very important when it comes to conversion of angiotensin 1 to angiotensin 2. So that's where you get angiotensin converting enzyme. That's primarily found in the lungs. So this is where this occurs. So anytime that somebody's taking an ACE inhibitor, when they're trying to regulate and control blood pressure, hypertension, these inhibitors will be effective in the lungs because that's where the primary ACE is found. So angiotensin converting enzymes in the lung primarily. So a lot of other activities occur in the lung as far as clearance and maintenance of these compounds. So let's go back and talk a little more about pulmonary fibrosis. Remember, I said pulmonary fibrosis can be caused by a variety of different aspects. We can look at pulmonary fibrosis. It's basically any type of inflammatory process in the alveolar septae and lung interstitium that causes thickening and scarring and changes in elastin and fibrin content and function. Causes. We can have autoimmune disease. We can have bacterial, virus. A variety of different drugs can cause pulmonary fibrosis, as well as inhalation of toxic gases. In this case, we're going to talk about inhalation of asbestos or other compounds. So there's a variety of things that can cause this inflammatory response that creates fibrosis within the interstitium. Okay, we can talk specifically about asbestos. It's a pulmonary disease caused by inhalation of asbestos. It causes diffuse pulmonary fibrosis and results in a decrease in lung volumes and lung compliance. We're going to talk about those in much more detail. But when we talk about fibrosis, think about a balloon. And you take a balloon, you can inflate it. It will deflate on its own due to its elastic recoil. However, if you take a lacquer finish or something and you put on the outside of this balloon, you make it stiffer. So now it will not expand very well, and it will still recoil, but it won't expand. So we decrease our tidal volumes, the volume we're able to get into our lungs in the first place. So a decrease in compliance means it decreases its ability to expand, and that decreases our lung volumes. We're not going to talk much about mesothelioma. That's just a cancer that can be triggered by asbestos. But cancer and diseases in the lung can also occur. Remember before I talked about, because the nature of the lung, the fact that it's got separations between different lobes, different components of the lung, it's easy to go in surgically and remove whole sections of the lung if necessary. And that would primarily due to either some type of injury or cancer that you may get. So that's just an example of what can happen. And so remember, pulmonary fibrosis is a very critical disease, and understand how it can occur and what happens with that. Now also, we haven't talked much, and we won't talk much about it during development. Here we look at the alveoli, the epithelium here in a newborn relative to an adult. So if you look at the two, you can see how immature and underdeveloped a newborn's lung is. So the newborn lung runs a very delicate balance in maintaining and obtaining enough gas exchange. But at least typically most newborns aren't going to go out and exercise, run a marathon, so they don't need a full capacity like adults do. So adult is capable of exceeding their metabolic demand at rest. Most infants primarily sit at rest. However, when they do cry, etc., they do increase their metabolic demand, and they do need additional oxygen. So you can see here we have an increase in alveolar number until 8 years of age. So the number of alveoli will increase, but as the number of alveoli increase, that increases our surface area. So the lungs are continuing to grow in early years, and so the alveolar diameter also increases into early adulthood. Now the fact that the diameter increases, that's just purely growth of body structure and the growth of the lung. So even the alveoli will get a little larger as the person grows. There's another disease called congenital diaphragmatic hernia, CDH. This is a disease that occurs in the fetus. Very early on in gestation, is what happens is the diaphragm does not completely close the cavity, the abdominal cavity, and separate that from the thoracic cavity. There is a small opening in that diaphragm. When that occurs, part of the abdominal contents, intestines, part of the stomach, etc., moves up into the chest. And when that occurs, it takes up some of the space and volume during development, and the lungs become underdeveloped. And when the lungs are underdeveloped, first of all, when a baby's born, they're immature. So the lungs are less mature than what you would see here. As well, they have a decrease in number of alveoli and surface area for gas exchange. So CDH, and this can be anywhere from mild to severe. So if a child is born with a CDH, congenital diaphragmatic hernia, it's important that they immediately surgically correct this as soon as possible, and that's by repairing the diaphragm. As well, they have to treat this baby with surfactant because it's immature and underdeveloped, the type 2 cells are not secreting surfactant sufficiently. And these babies are very difficult to treat, even though they may be closer to term or age-wise, their lungs are very immature. And also, it's important to know that lung function peaks under normal conditions at the age of 20 to 25 years of age. That's when you have optimal maximal lung function. And that's important to know because as you're exposed to various environmental factors, one being cigarette smoke, it's important to know that you can create damage to these lungs, especially while they're developing. So during development, you can slow development, you can hinder development, and then therefore when you do reach adulthood, 20 to 25 years of age, your lungs are not as good as they could have been had you not been exposed to a variety of other things that have impinged upon proper development. Now, another downside, excuse me, another downside of this is that at this age, once you peak lung function, you lose lung function from there on as you age. So one of the factors of aging is that you have a mild decrease in lung function as you age from that point. So that finishes our first lecture. Excuse me. So we're going to go and continue on with the next section. Do we have any questions so far? We've covered excuse me. We've covered a lot of information concerning structure and function. We've introduced you to many diseases so far, and you're going to see how these diseases relate to structure and function as we continue our discussion. No questions? Well, that's good. All right. Excuse me. Now, we already mentioned this before. We talked about why is the lung important for regulation of circulating compounds. We said that the lung does remove a lot of these circulating compounds. It acts as a filter. So all these other biological systems that occur, and they all secrete a variety of different factors in of themselves. And the interesting thing is they all receive a fraction of the total cardiac output. So if you look at this, a normal cardiac output of 5 liters per minute, and if you look at all the other organ systems, they all get a fraction of this cardiac output. So none of them receive the entire cardiac output like the lung does. So each of these secrete a variety of different compounds involved in their function. This all accumulates in the venous return and all comes back to the lung. So it's important for the lung that sees all of the cardiac output, or at least 98% of it, that it acts as a filter to maintain a homeostasis within the body so that these compounds do not have an accumulative effect, but that way they can be regulated much more finely at a moment-to-moment basis. So it's a very important function of the lungs. And once again, we already talked about that, the importance of how they regulate this function in relationship to gas exchange and lung function. Now, we've touched on the aspect of maintaining a fluid homeostasis, a fluid balance within the circulation, primarily within the lungs, and the importance of maintaining this fluid balance. We talked about how the interstitium within the lung is very thin, and that's important for gas exchange. We're going to talk much more detail about gas exchange, but one of the primary factors in sufficient gas exchange is distance of diffusion. So as we increase the distance of diffusion, in other words, the distance between the alveolar space and the blood space, if we increase the distance between them, gas diffusion decreases dramatically. So it's important to maintain that. Now, we've already talked about 2 different things that can affect that distance or that space and affect gas diffusion. One of those was fluid. So if we have edema, we're going to talk more specifically about edema, how we get pulmonary edema. But edema is the accumulation of fluid within that space. So if we accumulate fluid, it increases the distance that gas has to diffuse. And some of the gases are not highly soluble in liquid, so it is not the most effective way for gas exchange. So it's important to maintain that homeostasis in water balance. And so we're going to talk briefly about why the lungs have a very good way of doing that. Now, in this case, we look at the systemic circulation. We're going to use that as a comparison. So this is an example of filtration and reabsorption of water within the systemic capillaries. Okay, remember, aortic blood pressure is about 120/80 with a mean of about 100 millimeters of mercury. So that is the blood pressure that you're going to see going through the lumen systemically. Now, the adventitia, or the space in between the tissues and the blood vessel, there's what's called an oncotic pressure. Okay? The oncotic pressure is an accumulation of primarily proteins. So the more proteins we have within the adventitia, the surrounding tissue of the vasculature, we increase the oncotic pressure. Oncotic means it's got particles in it, and therefore it accumulates a higher fluid content and creates a pressure. So as what we're doing is we're generating a pressure outside of the vessel relative to a pressure inside the vessel. So the oncotic pressure is very stable within the tissue. So as we go from, now remember, this is a capillary bed, so as we go down the capillary tree toward the venous circulation, the oncotic pressure stays about the same. However, the capillary pressure, now remember, aortic blood pressure maybe have a mean of 100, but when we get down to the capillaries, we increase the total cross-sectional area, the total volume capacity dramatically, therefore the pressure drops. So as we get to the capillary bed, the capillary pressure is about 32 millimeters of mercury coming in. So as you can see, if the pressure inside the systemic capillary is 32, the pressure outside is 25, what direction is the fluid going to go? It's going to, what we call filtration. It's going to filter through the vessel wall into the interstitium. So fluid's going to move from the vessel into the interstitium. Now as we go further down the capillary and we get toward the venous circulation end of the capillary, the pressure drops even more. So it drops down to about 15 millimeters of mercury. Now as you see, as we cross this balance here, now the pressure outside the vessel is higher than the pressure inside the vessel. So we have a net movement of fluid into the vessel. So we get reabsorption. So all within the capillary bed, we get filtration and reabsorption. So that just helps to explain we do get fluid movement into that interstitium. Now this is systemically, under systemic circulation. Now if we compare this to the pulmonary circulation and the pulmonary capillaries, we have a different situation. Now remember, the pulmonary circulation is considered a low pressure system. The pulmonary arterial blood pressure is usually 25/8 relative to 120/80 in the systemic circulation, with a mean of 15. So you can see already the pulmonary circulation starts at a much lower pressure. So now when we talk about the pulmonary capillaries, which is even downstream further from the pulmonary artery itself, we start at a pressure of about 12 millimeters of mercury, and our oncotic pressure still stays about the same as you would see systemically at 25, and it stays constant. So because of the low capillary pressure in the pulmonary circulation, you see that fluid always moves into the vessel. We always have reabsorption. So the lung is designed as a low pressure system for one major reason, is to keep the lungs dry. In other words, we have to keep that fluid from the interstitium or between the epithelium and the blood vessels so that we have effective gas exchange. So in the lungs, the low pressure system helps to reabsorb fluid into the circulation to keep the lungs dry. Okay? So it's important to understand that. So now as we upset this balance, and we're going to talk about how that balance gets upset, you'll understand. So primary causes of pulmonary edema is if our capillary pressure becomes greater than oncotic pressure, and then we have filtration. And that can happen if we have left heart failure. So remember, the left heart or the left atrium is downstream from the lungs. So remember, we have the right atrium, right ventricle, pulmonary artery comes from the right ventricle, and then from the pulmonary artery it goes through the lungs and comes back to the left atrium. So now if we have left side heart failure, that means the left side's not going to pump blood out very effectively. Blood has a tendency to build up and build pressure proximal. So that means the pulmonary arteries, the pulmonary veins would increase in pressure. Therefore, the pressure would go above oncotic pressure, causing fluid to move into the interstitial space. You get pulmonary edema, and therefore you get poor gas exchange. Okay, so that's one way that occurs. Another is loss of plasma proteins, where we decrease oncotic pressure, and that can occur in starvation. So there are certain countries and certain areas where somebody may be prone to starvation. If we decrease this oncotic pressure, now our capillary pressure can actually exceed the oncotic pressure, and then we get pulmonary edema as well. And also there's other things that can cause this by increasing permeability of the vasculature. So either destruction of the alveolar capillary membrane, and that can occur by bacterial toxins, inhaling hot gases, anything that disrupts that epithelial, endothelial connection can cause an increase in permeability, and therefore fluid will more rapidly move across this barrier. And we're going to talk more about pulmonary edema when we talk about high altitude sickness, when we talk about hypoxia. Hypoxia causes a pulmonary vasoconstriction, which increases pulmonary vascular resistance and therefore increases pulmonary vascular pressure. And in doing so, that will cause pulmonary edema. So I'm sure you've seen it in many of the movies. People who go to high altitude, if they don't have adequate oxygen with them, they become hypoxic. And one of the first signs of having altitude sickness is they develop pulmonary edema, they develop a cough, and eventually they get pulmonary hemorrhage because the pressure becomes so high that now blood starts to leak across into the air spaces, and then they cough up blood. So we'll be talking about that a little more when we talk about hypoxia. So once again, looking at the circulation, we talk about left heart failure. We can have changes in lung volume, lung blood pressure increases. All these things can cause pulmonary edema, as well as loss of plasma proteins and starvation, increased permeability, bacterial toxins. All of these things can affect the circulation of the blood through the lungs and create edema. So that's one of the things that we pay close attention to. Now we're going to talk more specifically about a variety of different lung volumes and pulmonary function testing. First, just a little nomenclature. You are not going to have to know everything on here. Is what I want you to know from this is just a general method in how things are labeled and some of the nomenclature. So typically a primary symbol, all in capitals typically. You're looking at concentration of a gas in blood, fractional concentrations in dry gas, pressure or partial pressure, that's going to be a very important one. Volume of blood, this is Q. Q dot with a dot over it means the volume per unit time. As well, we have R is a respiratory exchange quotient, but this is also going to be when we refer to resistance. Saturation of hemoglobin with oxygen. We're going to talk in much detail about saturation. Volume of gas and volume of gas per minute time. Make sure you understand the difference between those if you see that nomenclature. As well, there's secondary symbols. Secondary symbols for the gas phase. So if we're talking about a gas, we're talking alveolar, barometric, dead space, which we've talked about a little bit, expired gas, inspired gas, total lung, tidal volume. And then there's secondary symbols for the blood phase. Now, most of these are all in lowercase. So we have arterial, capillary, end capillary, ideal, which we won't talk about much, venous, and mixed venous. So depending on where that blood phase is, these letters will indicate that. And these are just some examples. Concentration in arterial oxygen blood. So this is concentration, small a is arterial, and this is oxygen, O2. Okay, so make sure you understand what some of these things mean. So if you see these abbreviations, you will understand what they mean. And by knowing this nomenclature, it really gives you a lot of information. Whether it's volume or volume per minute, it really does help you discern what a question might be asking. With that said, when we're talking about volumes, we already talked about the different muscles involved, muscles of inspiration, primarily the diaphragm, external intercostals. If we do high activity inspiration, we would use the scalene, sternocleidomastoid muscles as accessory inspiratory muscles. And muscles of expiration, remember, typically under low activity or at rest, we use no muscles for expiration. It's passive. We get recoil, and the recoil is what causes expiration. However, if we increase our metabolic demand, we need to increase our respiratory rate or volume. We use the expiratory muscles, which would be the abdominal muscles, and the internal intercostals. Okay, those are your primary muscles of expiration. So remember, different ways that we become active when we have exercise. Coughing causes you to do active inspiration or expiration, vomiting. Lung diseases, that's what we're going to talk about primarily. They increase airway resistance, such as asthma. That'll change your lung volumes, lung functions, and even speaking and singing alters the muscles that you use, volumes that you use, and frequency. How do we measure the volumes? Basically, if you use a spirometer dates way back, and they were able to measure lung volumes. And this is the basic design. And obviously, the machines that they use today are all much more integrated and not as obvious as this. All they are is a little box now, and they'll give you the volumes. However, is how it works. If you take a cylinder, you fill it with water, you put a cylinder inside that cylinder upside down, so you have air trapped in here. Now, as you breathe into and out of this volume, basically this moves up and down. Okay, so it's just a pure volume measurement. And this was hooked to a pen on a slide. So as you inhale, exhale, it would just record different volumes. And so you actually could measure very accurately what your volumes were at different points in your ventilation. Now we're going to talk about very specific volumes, but that's how we were able to record these volumes. This you're going to have to know and know it well. This talks about different volumes and capacities. Some that we can measure directly, some that we can measure indirectly, and you're going to have to know which ones we can do which with. Now, volumes are designed to tell you different aspects of your ventilation. Capacities are a combination of two or more volumes. So when we look at this here, it's very straightforward if you pay attention to the way that this works, and then the way that the nomenclature is designed here, the terminology. This is a normal tidal volume, inspiration, expiration. So as you're sitting there at rest, that's a normal tidal volume, which for an average adult is about 500 ml. Make sure you remember these approximations because they're going to be very important for figuring out what's going on. Now, when I give you questions on the exam, I will keep everything in physiologic ranges. So obviously, if you see an answer that falls well out of a physiologic range, you know that's not a correct answer. So here you can see a tidal volume. Now, if we take at the end of expiration and we exhale as much as we can beyond a normal exhalation, this is called an expiratory reserve volume. Okay, so now we can breathe out this additional volume. And this normally is about 1,100 ml, about twice what your tidal volume is. So we have a lot more reserve in our lungs that we can push out, obviously using our abdominal muscles and our internal intercostal muscles to push that out. So normally this exhalation is passive. We don't need to use our expiratory muscles. But now if we use our expiratory muscles as much as we can, this is expiratory reserve volume. So then if you come back to a normal ventilation pattern, and now this time we say, okay, now inhale as much as you can on top of your normal passive inhalation. This is called an inspiratory reserve volume. Okay, so far these terms make sense. We can exhale an additional volume. We can inhale an additional volume relative to our normal resting ventilation. Okay, now we get to what we call our total lung capacity. So the total lung capacity is all the volume we can put, maximum volume we can put in our lungs. That includes our inspiratory reserve volume, our normal tidal volume, our expiratory reserve volume, and it also includes what's called a residual volume. This residual volume is the volume of gas, no matter how hard we try to exhale, we cannot push it out of our lungs. Because remember, our chest wall is such, it's fairly rigid. We can only squeeze it so far, and that's as far as we can squeeze it. So we still have a volume or capacity within our chest cavity, and therefore the lungs still maintain some volume to them. As you can see, that's about 1,200 ml. So our lungs are always inflated to a degree. And we're going to talk about how important that is. One, it refers to when we're talking about the use of surfactant and surface tension. If you maintain a partial inflation, the energy required to maximize that inflation is less relative to if it totally collapses. and that has to do with surface tension. An example of this would be if you take two pieces of glass, you put them together, and you put a little water in between them, just a little bit to wet it. Those two pieces of glass will actually slide real easily on each other. But if you take those two pieces of glass and try to pull them apart, straight apart, it's almost impossible. That little thin layer of water creates a bond that is extremely tight, and you cannot pull them apart. Okay? That's surface tension. It's the same idea like I mentioned earlier, that if you take one of those little rings and you're blowing bubbles, now you take that ring, you put it in pure water and try to blow a bubble. Can you blow a bubble? No. So what happens is it starts to form a bubble and it breaks. That's because the surface tension is very high. Surface tension means that the water molecules are held very tightly together. Therefore, it won't expand. Now, if we add soap to that water solution and then blow a bubble, we can blow a bubble. And depending on how much soap, depends on how big those bubbles can be. That's the same as surfactant. Surfactant is like a soap. You add that to the fluid and it allows them to expand easily. Now, another example here to maintain a particular volume is if you're blowing up a balloon. Take a brand new balloon and try to blow it up. That initial start is very hard. You have to put a lot of effort into it to get that balloon to start to expand. However, if your balloon is already partially expanded, it's a lot easier to continue to blow it up. That's the same thing with your lungs. If your lungs were to totally collapse, all of that fluid that's in your lungs would come into contact with itself, and that would take a lot of energy to pull that fluid apart and get the alveoli to expand. As well, if you have already an inflation there, first, you don't have the water in contact with itself, and second, you already have it started, so now the energy required to inflate it is less. So this residual volume is very important. And we're going to talk about that even a little further when we talk about a pneumothorax. So those are the initial volumes here. Very self-explanatory. They all make sense as far as residual, means what's left in there that you can't squeeze out. Reserve volume, whether it's expiratory or inspiratory. Tidal volume. Now if we look at the capacities, capacities are nothing more than the two or more volumes combined. Inspiratory capacity means what is the maximum volume that you can inhale. Well, that starts from end exhalation, so it's all of your inspiration, including the tidal volume. Vital capacity refers to the amount of gas that you can move within your lungs, so that's everything but the residual volume, because I said you can't move that. And then the last one, functional residual capacity. This is a very important one that's used diagnostically to try to study different disease aspects. So the reason here is functional residual capacity just indicates the maximum amount of volume that is left in your lungs after a normal expiration. So this functional residual capacity, depending on disease, can increase or it can decrease. Okay, so we're going to talk about different diseases that alter functional residual capacity, and those are major indicators of a disease. So make sure you understand these tidal volumes and capacities. And when we talk about various determinants of lung volumes, gender, age, height, there's a huge variability in what these volumes can be. These volumes that you see on here are just an average adult. Okay? So these volumes are very important, though, if you're comparing to normal values as trying to diagnose disease, as well as more importantly, longitudinal studies. So if you have somebody who has lung disease, now if you had a baseline study looking at these volumes and capacities before they had disease, it would be much easier to diagnose what's going on. Because of this variability, you can do these longitudinal studies. However, somebody who has early disease, and you get a recording of all their volumes and capacities, as that disease progresses, they can monitor it much more closely. So it's very important to understand what these volumes and capacities are and how they change as disease may progress. So as we look at this, an example of an exam question would be, given this information right here, calculate residual volume. So you would have to know that you'd have to add inspiratory capacity to functional residual capacity and then subtract the vital capacity in order to calculate residual volume. Okay? That's an example of a complex question that I might ask on the exam. I always recommend be able to draw this and label it. It only takes less than a minute to draw it and label it if you know what it is. So when you get a question like this, you can quickly just look at that and figure out what you need to add or subtract from each other. And I'll give you one tidbit and one tip. Sometimes I give you information you don't need. Okay? Just a tip. So as I was talking that we use these volumes and capacities to help decide what we have for disease and what type of disease that we might have. So now if we look at this, comparing residual volume to total lung capacity, this ratio is very important. Under normal conditions, a normal person who's healthy, that's 25%. So residual volume is 25% of total lung capacity. However, if we have an elevated ratio secondary to residual volume elevation, so that means total lung capacity may be the same, but residual volume is increased. That's an indicator of obstructive pulmonary disease. Likewise, if we have an elevated ratio secondary to total lung capacity decrease, that's an indicator of restrictive lung disease. Now, what's a restrictive lung disease? Two of them that come right up. One is fibrosis, okay, lung fibrosis. And the other, which we haven't talked about a lot yet, is respiratory distress syndrome. That is the lack of surfactant. Okay, we talked about how surfactant decreases our lung volumes by not allowing the lung to stretch. Okay, so it decreases surface tension. So surfactant's very important in that respect. So those would both be considered restrictive lung diseases. In other words, it restricts the lung from expanding. Obstructive pulmonary disease, we talked about several of those. That's anything that constricts or narrows the conductive airway. Okay, so make sure you understand the relationship of these changes relative to this ratio and how it can indicate what the disease is. So various factors that come into play, elastic recoil of the lung. Remember, we talked about emphysema, stretch of the lung, compliance, pulmonary fibrosis, or emphysema can go either way. We're going to talk about that in more detail. Muscle strength of inspiratory muscles. We haven't talked about this much, but that can come into play when we're talking about total lung capacity. Because if your muscle strength for inspiration is weak, that's going to decrease total lung capacity. Because inspiratory muscles are required for inspiration. So if they're weak, we can't inspire as much. So our total lung capacity will decrease, and that's an indicator of restrictive lung disease. Recoil of the chest wall. We typically don't run into too much where we involve altering the recoil of the chest wall. But remember, when we said exhalation is recoil, it's recoil of the lungs. It's also recoil of the chest wall. The chest wall, remember, as we inhale, the chest wall expands. So that expansion, restriction, or increased ease of expansion is important. Now, different things that can affect that, of course, is muscle strength. That affects recoil of the chest wall. Or you could have some type of injury that also affects recoil of the chest wall. We're going to talk about those in more detail, the relationship of the chest wall forces relative to those of the lung forces. So examples are when the chest wall muscles are weak, the FRC decreases. In other words, lung elastic recoil becomes greater than chest wall muscle recoil. And that'll make more sense in a little bit when we talk about some other factors here. But both of those have separate but yet related functions. Lung elastic recoil, remember the elasticity of the alveoli and the lung itself, as well as the chest wall due to its expansion and ability to recoil. In the presence of airway obstruction, the FRC increases. Now, in this case, that's because of premature airway closure. So if our airways are somewhat occluded and we have more resistance in the airways, we're going to talk very specifically why during exhalation we can get a total collapse of those airways prematurely. So therefore, if you have obstructive airway disease, we increase the FRC because we have a collapse of those airways before we finish exhaling. Okay, so we'll talk about that in more detail. But all of these relate to residual volume, because remember, residual volume is a large part of FRC. Now, different measurements that we can do for residual volume and total lung capacity use either a body plethysmograph or a helium dilution. We'll talk about those in more detail. Helium dilution. That's where we take a gas, an inert gas, such as helium, mix it in with normal air. Helium is neither absorbed or diffuses in the lung, nor do we create helium and add to it. So helium stays within the airspace, so it doesn't move. And that's why helium is used. Now, once again, if we hook ourselves up to a spirometer type device in which we have a known concentration of helium and a known starting volume, okay, so now we can have a calculated starting point, and now we can measure a variety of different volumes depending on where we start our inspiration. So what we're going to do is we're going to mix this known concentration of helium with our volume in our lungs that has no helium. So as we now open this valve and breathe and we let it go to equilibrium, we can do a calculation using this formula, very straightforward, to recalculate this volume. So the dilution of this concentration in this volume will give us this volume. So now if we start this, if we start at end expiration, think about where we're going to be. We're going to be able to measure. So the volume left here will be FRC. Okay, so now we can measure FRC if we start this equilibration at end expiration. Or we can do a total lung volume, or a total lung capacity, if we start at maximal expiration and then open this. Okay, so depending on where we start, so we can basically calculate using helium dilution any volume that we need to within the lungs, other than residual volume. Okay, we can't measure residual volume. So make sure you can do this calculation. Like I said, it's very straightforward. to calculate volume 1 or volume 2. Primarily, you're going to be able to calculate volume 2, and this is just an example here of a question you might get. So make sure you know how to do that. This here is using a body plethysmograph. It's a much more complicated system because what it does is it takes a pressure differential from within this box and the outside of the box to calculate the volume changes in the box. I am not going to ask you to calculate using a body plethysmograph. It's more complicated to understand, and the device that they use is more complicated. It is not as straightforward. However, if they use this clinically, basically they have a computer system attached to this that gives you all of your variables that you need to know. But it's the same concept. Once again, you start breathing at various volumes and capacities, and therefore you can calculate due to the pressure differences within the box and outside of the box to give you these volume changes. Because remember, your chest wall expands and contracts as you breathe, and that volume indicates directly the volume change of the lung inside your chest wall. So these volumes, once again, are very important. Another test that is done that gives you an indication of disease is called forced expiratory volume. So once again, in this case, clinically, you would do a normal tidal volume, inspire, expire, under normal conditions. And now you would be asked to inspire maximally. Okay, remember we talked about maximal inspiration. And at this point, they're going to have you forcefully expire, breathe out as fast as you can. Now, the amount of volume that you can expire in 1 second is called forced expiratory volume 1, FEV1. That's a forced expiratory volume in 1 second. And if you continue to expire forcefully, this is called your forced vital capacity. This is the maximum amount that you can exhale. Now, we've talked about those volumes. Now, if you look at this ratio of FEV1 over forced vital capacity, under normal conditions with a normal healthy person, it's about 3 liters to 4 liters, or 75%. In other words, you can exhale 75% of the air in your lungs in 1 second under normal conditions if you're healthy. Okay, so now we're going to talk about how this can change. So factors that can decrease this ratio are decrease in muscle strength, increase in airway resistance, or increase in lung compliance. Those are the different things that can cause this ratio to change. So we'll look at an example. This here is our normal forced expiratory volume. So maximal inhalation, maximal exhalation. If you do this on a curve, you can actually measure this and time it. Now, if you have emphysema, this is what it looks like. So already you can tell just from these volumes that our FRC is dramatically increased. Okay, as we mentioned, anything that has a restrictive airway during exhalation causes premature closure of that airway, therefore trapping more air in your lungs. Hence, we have a higher residual volume and creating a higher FRC. Also, we have a diminished vital capacity, which makes sense because now if we can't exhale as much, our vital capacity is going to be decreased. But an interesting thing here is in emphysema, you see the peak up here under normal conditions This is our maximum volume. But with emphysema, you can actually exceed this. And that's due to the loss of the elastic recoil in the lungs, loss of elastin, loss of collagen. You have a breakdown of your interstitial tissue, so your compliance increases. So your lungs expand easily and readily. So hence, you end up at a little higher volume here. And because you can't exhale as much, you end up moving your whole inspiratory-expiratory curve upward. And so you're breathing a little higher on the scale. Now, what's one of the major causes of emphysema? Smoking. Okay? There are compounds in cigarette smoke that increase protease production in your lungs. These proteases they break down the elastin, they break down the collagen, therefore they disrupt and destroy the septate of the alveoli. So therefore, because of a loss of tissue, you have a loss of alveoli, and you get bigger alveoli, you get thinner walls, and therefore you lose a huge amount of surface area, but you also increase compliance. But you also lose recoil, because without that elastin, your lung will not recoil. So in emphysema, once again, you have to use your expiratory muscles to exhale. And once again, people with emphysema are typically very thin because they're consuming so much energy to exhale. So if you do this ratio, you can see now you're, instead of 75%, you're only at 33%. So all of these factors play into and add to determining what disease you might have. So before we go into these other curves that give us more information, we'll pick this up on Tuesday, and we'll see you then. This is a blood vessel. This is the interstitium, that small area between the blood vessels and, say, the alveoli. But here, this is systemic. So as what here, there's no airway here. This is just your normal vasculature systemically. This is your capillary bed in the pulmonary circulation. So in the pulmonary circulation, we start with a much lower pressure than we do here. Therefore, we have only reabsorption of fluid because the pressure in the vessel is lower than it is in your systemic circulation.
If this is like the capillary, because you said that you want to keep the lungs dry, so you reabsorb the fluid.
Correct. You reabsorb it from the interstitium.
Oh, from the, okay, so it's not into, it's from. I wrote it wrong.
Well, right. It's from the interstitium. Correct.
And then